Appreciate y'all tuning in this morning, and let's move on to it. I wanted to talk. Well, take me out of there for a second. Oh, God. It's going great, let me tell you. I wanted to talk about EKGs. EKGs. I think EKGs are hard to talk about because they're very dry. They're not really interesting. But they also are really important. So it's like a skill you got to have, but it takes a lot to kind of get comfortable with them. But that's very hard to do in the setting of like a talk, a lecture, or for God's sake, in your else case, 2 hours of sitting somebody else watching them talk about EKGs. That can be kind of difficult. So what I really want to do is not be like, here's your basic EKG class. This is assuming that you know something about EKGs already. What I want to talk about is how I kind of think about EKGs. So it's not all the criteria, it's not all that kind of stuff. It's like when somebody hands me an EKG, when I'm sitting there at my desk, like on a shift, what do I think about when I'm looking through those EKGs? At least what's the big stuff? Because we're not going to get all the cardiology type stuff. We're not going to be the Floyd miracles that can pick out like all the little interesting findings or know that exons means we got to kind of focus on the big stuff, because we're really not, from an EMS standpoint, I think we really don't get kind of the follow-up with it, like, oh yeah, this EKG looked like this, you said it looked like this, it actually was this. We just don't get that based on our system, and that's kind of a detriment. But hopefully this will give you a little bit of a different way to think about it, or something else that will let you think about EKGs, if you find them tough, a little bit differently, make it a little bit easier. So, all right, enough intro. EKGs. This is how you make an EKG. It's actually not that complex. This is the circuit diagram. We made one of these when I was an undergrad in one of our biosensor classes or something like that. I was an engineer. And it's really not that complicated. You could do it based on the stuff that you could go to Radio Shack, if Radio Shack existed, but I guess easily buy off of Amazon. All you do is put some resistors and a couple other things together in a little circuit board, and there you get an EKG. And the ones that you buy in a prepackaged form as a monitor or as an EKG machine, a 12-lead machine or something like that, are a little different, have some filters and there's things to make it nicer. But in the end, it's really pretty simple. It kind of got to bring up what does an EKG do? This is something you can build in your garage. What is it we're actually measuring? An EKG, and let's say EKG means 12-lead EKG from now on for the purposes of this presentation. An EKG is nothing other than the graphical representation of the direction and magnitude of electrical current through the heart, or more specifically through the chest. So EKGs can kind of be a little bit of a mystery when you look at it as just like, here's this squiggly line, and how does that squiggly line translate into anything that's actually helpful for us? This is a picture along 12 different axes, or along 12 different really lines that shows you what direction electricity is moving through your chest, or through whatever you've got the EKG leads stuck to. How did it start out initially? This is kind of cool. You've heard like Eindhoven and that guy. I think this is actually Eindhoven. This is the early EKG. And you see what he's got. He's got a bunch of circuitry back there, and that's not really the important part. He's got basically a way to view it here. He's got conductors here, or essentially sensors here, and then a little bit of processing stuff back there. And again, this can be the size of your iPhone now with really no difficulty. But this was a room size thing. And if you look at what he's got, this should all look familiar. He's got his hands in buckets or pots, basically. This guy does. He's got his hands in pots of salt water. And he's got one here. He's got one here, i.e. right arm, left arm, and then his left foot. That sounds sort of similar to the leads that we put on people, right? And then you may ask, well, what's his right foot doing? His right foot is technically grounded, although not all that well. You get a little bit of a better picture when you put in a ground. But this is the early EKG. It's the same leads. It's a right arm lead, a left arm lead, and then a left foot lead. Just exactly as you might see on your Life Pack, or on your Zoll, or on whatever, Medtronic, whatever it is that you have in the emergency department that you're working with. The leads are exactly the same, and they're just there to measure the vector of electricity that's moving through your chest at any point. So the EKG machine picks up from each of these sensors. Here's a sensor, picks up the electrical signal coming to that sensor, and then puts it together and relays it along a set of axes that rotate through the heart. And that's the thing that actually generates, which lead goes out there. So lead one, which goes from the right shoulder to the left shoulder, you got to kind of reverse it looking at the heart itself. Starts here, here's basically, think about it this way. Here is your right shoulder over here. Here's your left shoulder over here. And it is measuring electricity as it goes essentially through your heart, which is the electrical producing thing, towards your left shoulder. And that's where lead one comes from. That's the axis. That's how lead one makes its direction. Lead two measures the electrical current that's going from your sort of left shoulder down to your right shoulder down to your left foot. I'm backwards again. And that's where you generate lead two. So it goes like that. That's how you generate each of those electrical things. You could think of it like a camera. Where each position of the camera is checking out the way that electricity is measuring along the heart itself. Now we can get into vectors and math and all that kind of stuff, but that's pretty boring. So I'm going to try to blow on past that for a minute here. In the end, you create this thing. So what do the leads look like? Lead one is the electrical current that's going across the heart from shoulder to shoulder, essentially. Lead AVL is based on its axis going up and that way. Lead two looks something like that. Lead three looks like that. Lead three looks like that. AVF looks basically straight down through the heart. Each lead is just a little brief measurement, a 2.5 second measurement in the standard 12 lead of what the electrical current in the heart is doing and which way it's going in any direction. So a positive deflection in lead one means that electrical current is flowing along the positive lead one axis, meaning it's going from right to left. It's following the arrow. A positive deflection in lead AVF down here means that it's going from the positive part down to the negative part. So it's going down through the heart, which is kind of the normal way that hearts beat. That means that anything that's primarily negative, current is flowing in the opposite direction. So we don't talk about lead AVR very much because it's not helpful in most cases, because it kind of goes, I didn't even put it on here, it goes from down here up that direction, like from your left foot up towards your right shoulder. Not all that helpful in most stuff that we're looking for at least the diagnostic kind of stuff or the rule out kind of stuff. Generally, there's a few things you can do with it, but it does go something like that. So it's primarily negative. Electricity generally travels from up here down to here, and so it is a primarily negative lead because it's going the opposite direction of the arrow. Now, that's the basics behind it. That is in the the coronal plane, something like that. Oh man, I don't have to go through all that. Shoot. Stand by 1 second. Cool animation, huh? Yeah, it looks great. Even better the second time. There we go. If you turn that picture and start looking at it through the chest itself, as if you cut yourself in half, you generate the precordial leads. So now we're looking at the heart in 3 dimensions instead of just 2. When it was this way, we were looking at it basically side to side and up and down. Now we're looking at it front to back. And that's why you add on the precordial leads to make up the rest of the 12 lead itself. And that's V1 through V6. You can put on the V4R lead over here and look at it in another direction. It's all about just what direction the electricity is flowing. And why add on these extra 12 leads? Because it lets you look at, instead of just like up and down and kind of top and bottom, it now lets you look at front to back. So anterior, posterior, inferior, and lateral. It gives you, again, a 3-dimensional picture. And worth noting too, it's really important actually for the standardization and for what we call the 12 lead EKG and interpretation of it. You got to put the stickers on right. And the stickers are an ALS skill. It's a BLS skill. It's not an EMR skill, but if in at least Kentucky and in most places an EMT can obtain a 12 lead EKG. Now you're not really supposed to interpret it. We can get into that in a little bit, but you got to know where the stickers are. So this is an everybody skill. Everybody needs to know how to do this. Paramedics mess this up just as much as everybody. know where the stickers are supposed to go. It's not like V1, V2, V3 kind of here, and kind of off there. It's pretty prescribed. Go about the nipple line, V1 on one side of the sternum, V2 on the other side. Excuse me, V3, V4 sits essentially what should be male nipple line, kind of right in the middle. V6 sits at the axillary line, and then 3 and 5 go in between those. You kind of got to get that right in order to make an accurate interpretation based on the rules that we have kind of arbitrarily set for EKG interpretation. If you don't do it exactly right, yeah, it still makes a picture, but maybe it doesn't make kind of the right picture. I've actually had a patient when I think it was a fellow at the time. They got his initial EKG, clearly no ST elevation or anything like that. But the guy looked like absolute butt. He was sweaty. He was like kind of doing that number. He was kind of pale, like something doesn't look right. We went in, we looked at where they had left the stickers on him, and V1 and V2 were like up here, and V4 was kind of like, you can't see me, but like here. And we're like, all right, wait a minute, let's redo this. Put the stickers on right, boom, big anterolateral STEMI, which we wouldn't have seen if we hadn't placed the leads right. So by convention, if we're going to do the stuff that, active or work in the system that we're set up with, which is what we got to do, then you got to put the leads on the right spot. So lead placement is a skill. It's an important thing to do, and it's something that you got to do. Everybody thinks they know how to do it, and that's cool. Most people do know how to do it, but you got to actually implement and activate and do it right. All right, it would not be an EKG course if we didn't talk about the electrical conducting system of the heart. So the heart has a bunch of cells that are specifically designed to conduct electricity and move it rapidly, or in some cases not so rapidly, through the heart itself, so that your heart beats effectively. And why does it do this? Well, because if it didn't, then we wouldn't have a functioning heart. The SA node at the top is where the electrical signal generally comes from. The AV node sits, it's really just, it's not like a particular lump, but it's a sort of a lump of cells that sit right at, again, the junction of the atria and the ventricles. And then you have conducting fibers that go down on both sides of the ventricles. When these fibers are activated, they spread an electrical charge through the ventricles themselves, just like a pacer, and the muscle squeezes when it gets that electrical charge. That's how it basically works. So let's talk about how an EKG gets made real quick, and I'll try not to belabor the point, but if you haven't seen it, here's what it is. So heart decides it needs to beat. The automaticity of the SA node goes off, says, all right, time to make an impulse. That's what I do. And it goes bloop, and it creates a little electrical impulse, a little shock. That shock doesn't actually do anything. The SA node itself doesn't actually register as anything like that. It's just a little bump of cells. It's the little, like, the starting charge for the dynamite. It in and of itself is pretty small. It is when it actually goes through the atria and wraps across there that you start to see a waveform. And that waveform is the P wave. So P wave is as electricity goes from the SA node down to the AV node. That's the conduction there. Now, the charge gets to the AV node, and the AV node kind of holds on to it for a minute. And so in the EKG, you get this pause following the P wave. So here's where the charge started. Here's as it goes through the atria. Here's where it stops a second. The AV node holds on to it because it wouldn't be great if it just immediately transmitted it down to the ventricles, because then basically the whole heart, instead of squeezing like top, bottom, it would just be going all, and it would squeeze a little bit of blood forward probably, but a lot of blood backwards as well. And so it's much more better if the atria can go squeeze, empty down to the ventricles squeeze up into, the brain or wherever it is that's trying to go. Your organs, those important things. So that pause is really important to let the ventricles fill up and develop pressure. Talking too much, sorry. After the the AV node releases that charge, though, it goes down along the AV septum, which starts to create your QRS complex, usually an R wave. And then when it gets to the bottom of the heart, it goes around, makes a U-turn, and then goes back up the other direction, which makes the rest of your QRS segment. Almost done with this guy here. After that, there is a brief pause because your cells have all been like, whoa, that was weird. This is your refractory period, the ST interval. And then your cells, essentially the ventricles, the atria do it too, but the ventricles repolarize. And that repolarization is sort of the opposite of the polarization that had just happened, sort of the opposite direction. It is an electrical current, but it looks a little bit different. And so instead of another QRS complex, you get a T wave. So just to review one more time with feeling, SA node starts, atria contract, it makes the P wave. PR interval is here because that's where the AV node is holding on to electricity before it is released into the septum, which starts your QRS complex. It gets to the bottom of the heart, goes back up the sides, up the ventricles, which causes you the rest of the QRS complex. And then everything sits for a minute during the ST segment. And after everything sits, you get repolarization, and the repolarization is your T wave. That is the way that the heart works, and that's the way the electrical signals in the heart work. Now, that is hopefully the most this is basic EKG stuff that I will get to today. I'm hoping to just kind of move on from here and say, well, everybody kind of knows probably a little bit about EKGs. Let's talk about how to interpret it a little bit more. When we are interpreting an EKG, how do we tell people to do it? How do we teach people to do it? If we're going to go through, an EKG book or something, and somebody asks me, well, how do you look at an EKG? Well, here's how you're supposed to look at an EKG. And I will credit Bill Young, not Bill Young of EKU, who is also a good guy, but Bill Young at UK, who was one of the faculty when I was a resident, who made EKGs. Well, he basically framed the way that I think about all EKGs. Maybe it's because he said it often. Maybe it's because it's actually a good way of doing it. Either way, thanks, Bill. This is the way that I do it. When we are looking at an EKG, don't look at the big picture and say, oh God, what do I do with this thing? This looks funny. What's this over here? You got to have a systematic way of going through it. Once you develop that systematic way of going through it, things actually get quite a bit easier. Not knowing anything else, just having a good way to go through it to sort out what each of those things means is really important. So when people ask, what do we do? Here's the official book answer. You figure out the rate, you look at the rhythm, then you look at the axes, you look at the intervals, you look for signs of ischemia, you look for infarcts, and then you look for other pattern recognition type stuff. Rate, rhythm, axis, intervals, ischemia, infarcts, and then other stuff. And that will let you read an EKG. And again, just doing that, just having an organized way to go through it will make a big difference. What's it look like to go through all that stuff? Rate. Let's talk about the rate. How do you calculate a rate? Well, the easiest thing is you look at the top of the EKG where there's a bar up here, again, we're going to say 12 leads here, where there's a bar up here that says ventricular rate. And you go with that. It says 70, it says 110, it says 160. That is a good way to determine the rate. Now, on a 4-lead or something like that, it may give you, if you're watching the monitor itself, it's going to give you an instantaneous rate. It's going to give you a rate at that particular moment. The rest of the 12-lead is doing it based on the entire 10-second period. How can you yourself calculate a rate if for some reason that didn't show up, or you don't trust it, or it seems to be it's going to count QRSs, but if you think it's counting big T waves or something like that as well and giving you twice the number and you want to know what the rate is, how do you do that? Again, going back to sort of what we learned when we were first looking at EKGs, you can look at the number of boxes in between them. And each box is, let me see here, each big box is 1/5 of a second. So 5 big boxes gives you a second. When you convert that into math, if you start at this QRS complex over here and say, what does another QRS complex 1 big box away gives you, that would give you a rate of 300. If it's 2 big boxes, it's 150. And again, this is all based on the math. I sat down and actually did this again last night just to prove to myself that it continues to work. If it's 3 big boxes between QRS complexes, then it's at 100. If it's 4, it's 75, it's 60, 50, and then it kind of goes down from there. That works pretty well in a scenario like this. Look at your QRS, say, all right, there is 1, 2, it's pretty faint, sorry, 3 and a half. So 300, 150, 100, and it's somewhere between 100 and 75. And the number 100% doesn't make that big a difference. 8 does a rate of 85 make a difference from a rate of 80? No, probably not. But that works. I guess I could have just showed you that again. So again, this one here, somewhere between, let's call it 80. It lies somewhere between 175 or something like that. That's cool, as long as your rhythm is regular, because you're basing it on the space between this QRS complex and this QRS complex. If you look at something like this and you try to calculate this rate, that all goes to hell. Here is, if we count these first ones here, here's where we're starting where we're going to look from. So one box would be 300. It's not, two would be 150. Three would be at 100. Four would be at 75. So again, we get a rate somewhere between 75 and 100 right here. So let's call it 80. Okay, great. But if you measure between these next ones, there we go. Too much. Take myself out for a second. If you measure between the next ones here, starting here, that would be 300. That'd be a rate of 150. That'd be a rate of 100, 75. Still haven't touched it. 60. We end up between 50 and 60. Right about yonder. There it goes. And so you could say, the rate is maybe it's a rate of 90, or maybe it's a rate of 58. And that could make a big difference, because a rate of between 100 and 150, which is very possible, you might see on here, that is a significant difference. 80 and 85, no big deal. 100 to 160 may make a big deal in terms of your interpretation of it. So what do you do about that? This is the way we've been pretty much taught to do it. I don't like this way for that reason. Let's do this. Take that the standard 12 lead EKG is 10 seconds long. If you count the number of QRS complexes along a rhythm strip that you see on that 12 lead EKG, multiply that by 6. That gives you how many complexes there actually are in 60 seconds. And that will work to determine the actual rate. That gives you the actual, a better approximation of the rate itself, because it's not based on the space between each individual beat that's kind of like mathematicized out. It is the actual number of complexes that occurred in that 10-second period. It's literally just like taking a pulse. So as long as your standard EKG is 10 seconds long, or represents 10 seconds of time, you can take how many QRS complexes down at you can just count down at the bottom, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, there's a couple behind me, 11, 12, 13, 14, multiply that by 6, which is what, 60 plus 24, 84. So rather than that discrepancy, is it 100, is it 50? No, the true rate is actually 84. It's just irregular. I use this all the time. If there's no printed number at the top, I just count the number of QRS complexes on the EKG in a line and then go with that. And that's a good way to do it. I would almost say forget about the other stuff, but this is a good way to do it. And this is an accurate way to do it. All right. Rhythm. We talked about the rate. Now let's talk about the rhythm itself. There are basically some questions that you need to answer here. And that is, are there P waves? If there are P waves, is there a P wave before each QRS? And is there a QRS following each P wave? So sinus rhythm, when we say sinus rhythm, means it starts at the sinus node, the SA node, this guy up in the upper top of the chest. There are other rhythms and other places where you can get electrical impulses from. Sometimes it comes from the AV node. Sometimes it comes from the ventricles. Sometimes it comes from the atria. Either one is possible, and you can get a non-sinus rhythm. Sinus rhythm specifically refers to beats coming from the SA node at the top that propagate down through the rest of the heart. So generating P waves, essentially. The questions when you're determining rate, number one, are there P waves? And then you can make some assumptions from it. If there's no P waves, well, then there's basically two things this is. It's either AFib, maybe a flutter, although a flutter has, like, I would say probably has P waves, they're just funny looking, or VT. So there's no P waves, it's AFib or it's VT, or it could be, I suppose, like complete SA node standstill, but those are the ones you're commonly going to see. Then after we've determined, are there P waves? Are there P waves before each QRS? If there are not P waves before each QRS, you got to think, is this a high degree block? Could be third degree block, could be a Mobitz 2 block. But if there's not a P wave before each QRS, and it seems not just an ectopic beat or a PVC, then you got to be worried about a high degree block. Then the next question, is there a QRS following each P wave? So are the P waves, is there a P before each Q? And then does every P generate a QRS? If the answer is no to that, then you might be looking at something like a second degree block, as we kind of mentioned before. And then is there the same distance between each QRS segment and each P wave? So are there P waves? Is there a P wave before each QRS? Is there a QRS that follows each P wave? And it is important to differentiate there. And then is there the same distance between each QRS and each P wave? That will give you essentially the rhythm and sort of block determination that you need to do. So to look at that a little differently here, let's see. In this case, let's look down at the rhythm strip here. So there is a P wave and a QRS. And is there a P wave and a QRS? Yes. P wave, QRS, P wave, QRS, P wave, QRS. Yes. P wave. So P waves. So it does appear to be a sinus rhythm. P wave, P wave here, no QRS following it. This is some kind of block. We can look at it a little bit more later and kind of determine, but this is a sinus rhythm because there are P waves, but not every P wave generates a QRS. So this is some kind of high degree block. It's either a second degree block or third degree block in this case. But we can look at it a little bit more closely once we get into it. So are there P waves? Is there a QRS following each P? Is there a P that generates a QRS for each one? And then are the P waves all looking the same? Here you might kind of look at the same thing. Biggest question, are there P waves? And well, there's some funny squiggles, but no obvious P waves down here. So no obvious P waves. Again, that's basically usually two things. It's either a ventricular rhythm or it's AFib, and AFib is going to be the common one. So this is in this case AFib. There's no P waves at all. And then you may look at this one here. Let's use this lead 2 rhythm strip right there. So are there P waves? Yes, I see a P wave. Yes, I see a P wave. But there's not I already know there's not a QRS following that. And maybe there's a QRS following that one, but I don't know. That one's kind of just chilling out there. There's another one. There's another one where there's no QRS following it. So again, some kind of high degree block. In this case, this is a third degree heart block, and we'll get into the blocks in a little bit. But is there a P wave? Or sorry, are there P waves? Is there a P before each QRS? Is there a QRS following each P? And then do the P waves all look the same in relation to the QRS? That's what you need to know about P waves. And again, we're just talking about how you're supposed to interpret EKGs. We'll get into the nitty gritty in a little bit, stuff that's a little bit more practical. How about access? I'm not going to talk about access. It's never been helpful to me. I could figure it out if I absolutely had to. I have never made any kind of EKG, anything based on an axis. And somebody out there is probably like, well, it could determine left anterior fascicular. I don't care. I just do not. This is the one I have always said, if it comes down to axis, I'm going to miss it. If it comes down to patient care and the patient care is absolutely relying on knowing the axis of this EKG, there should be enough other stuff. Axis isn't really all that important. I'm not telling you not to learn it. I just don't. It's not a helpful thing to me. Again, somebody is mad at me right now, and that's okay. So how about intervals? Again, this is how I look at it. We've determined rate. We've determined rhythm, basically. I looked at the axis. Now let's look at the intervals themselves. I don't want to get into all the numbers and all that kind of stuff, but I will just bring up again, what do the intervals mean? You basically got four that you're really interested in. One is the PR interval, the space between the start of the P wave and the start of the QRS, or the R wave and the QRS complex. This is how long it takes electricity to go through the atria. That's what that measurement is. The PR interval is how long it takes for electricity to start and go through the atria. Then you've got the QRS, we'll call it width or, interval, if you want to call it that. That's how long it takes electricity to travel through the ventricles. And then you've got the ST segment, which isn't super important except in doing like ischemia, but that's an interval that's there, but it doesn't really have a time that's usually on it. And then you've got the QT segment. And QT is from the start of the QRS to the end of the T wave. This is usually calculated out for you because it's hard to make that calculation. What's QT tell you? It tells you how long electricity takes to go through the ventricles and then the ventricles to turn back around, essentially, before you can safely have another ventricular beat. That's what the QT interval tells you, is how long you have before it's safe for electricity to travel back through the heart. It's more a marker of like, how likely is this person to develop bad stuff that can happen as a result of aberrant beats that happen in there. It's more something that we measure than something your body really cares about. Although your body does care about it if it dies. I guess it is important after all. What are the intervals supposed to be? This is, kind of the bane of my existence, and trying to tell you exactly what the number is supposed to be is hard. So let's say this. Your PR interval is supposed to be one big box or less. If it is longer than one big box, then it is usually a first degree block, but could be like a Mobitz 2 block. If it is bigger than one big box, that means that electricity is being slowed going through the atria. Your QRS is supposed to be 3 little boxes or less. And if it is bigger than 3 little boxes, then that is a sign that electricity is having trouble going, in an expeditious fashion through your ventricles. And then your QT is supposed to be that, the number actually changes a lot depending on your age, and it makes a big difference to you depending on how fast your heart's going. The QT itself, let's just say, is supposed to be about less than half of the whole interval between beats. So if you're spending more than half your time in this dangerous kind of state, which again is what the QT interval is, then that's bad. That's a long QT, and that just means that there's more time set up where if an electrical signal were to hit sometime in the middle of the QT interval, if another electrical signal were to hit in here, that can cause your heart to go into a dysrhythmia. That's the way that, again, I kind of think about the QT interval. It's how long is the heart in a dangerous period before it resets and it's safe again. So PR interval is one big box, QRS is 3 little boxes, QT is half the time to the next QRS complex. Moving on from there. I mentioned all this already. Moving on. All right. Rate, rhythm, axis, intervals, and then let's look at ischemia. What does ischemia look like? Ischemia different from infarct. Important to kind of note that. Ischemia means heart is not getting enough blood supply, or that it's under more strain than it is used to handling. It is a lack of sufficient blood flow, but not no blood flow. It's not dying tissues, it's hurting tissues, if you want to call it that. What does ischemia look like on an EKG? It is ST depression, generally speaking, and an ST depression of a magnitude of about 0.5 millimeter, or 1/2 of a small box, which is little bitty bit, is significant. There are different morphologies of ischemia. The flat ones and the downsloping ones, like that one. So flat, you see how there is ST depression here. See how that's kind of flat? This one has a little bit of a slope down. This one has a little bit of a downslope. This one's kind of flat. This one has a lot of a downslope. The ones that are flat or downsloping, those are concerning. Those are ones that actually probably indicate, yeah, some heart tissue is not getting sufficient quantity of blood. Maybe the heart tissue is not dying necessarily, but it is saying I'm not getting enough blood flow. And that can be for a number of different reasons. Maybe it's a shock state. Maybe it's just their blood pressure is crappy and you're literally not perfusing the heart. Maybe it's because they have a subtotal coronary occlusion that's keeping it from getting enough blood flow. Maybe it's going too fast and it's just hurting. It's consuming more oxygen and more substrate than it is able to get to. That's the ischemia part. Let's look at a couple of examples here. When you look at, we've done rate, rhythm, axis, intervals, ischemia, looking at the ST segments here, which is what we'll look at for infarcts as well. You notice that there is some here horizontal, here some down sloping ST segments. Not so much here. You can note that one's significantly down. There is some depression here. It's sort of flat. The upsloping ones are a little bit, they're not as clearly bad. But when you get out to the lateral leads here, significant flat ST depression, significant flat ST depression. It's over here too, if I can get my big old head out of the way here. There it is. significant flat ST depression. Downsloping or flat ST depression is bad. It may not be a conclusive sign of something, exactly what's going on, but it's basically saying the heart's under stress and not getting as much blood flow as it needs. Worth noting too, if you look at a second example here, you do notice that there is a little bit more flat ST depression out here, and there's some down here. Just trust me, it's there. And then when we look through the inferior leads over here, yeah, kind of flat-ish, and that's all kind of bad. So you may look at this and say, all right, he's got ischemia, he's got ischemic changes, 2, 3 AVF, which is where it's most prominent and most flat. We'd say, well, okay, that sounds like some likely inferior ischemia. That's concerning. Maybe he's got a subtotal occlusion in like his right corner or something like that, because it localizes, right? 2, 3 AVF is our inferior leads. You have to watch that though, because ischemia or what you could call ischemia can actually be just the reciprocal change, if you remember that term, the reciprocal change going in the opposite direction for ST elevation. And sure enough, when you look at AVL here, this isn't ischemia. It is a reciprocal change from AVL where there is just enough significant ST elevation to call a STEMI. So you got to watch whenever you see something that looks like ischemia on your EKG, you got to look on the opposite side. So if it's inferior, you got to look lateral and a little bit anterior. If it's anterior, you got to look inferior, and you got to scrutinize it really closely, because if there is signs of ischemia, be damn sure that there is not actually a STEMI that you had just overlooked before. So if you see ischemia, make sure you're checking the rest of the EKG and prove that there's not a STEMI that you just overlooked before. And a lot of times you may find it. Rate, rhythm, axis, intervals, ischemia, infarcts. What are we looking at infarct-wise? You're looking again at the ST segment, and you're looking for ST elevation. There are a couple of different ways that ST elevation can look. This is the classic one. And again, if you were to since I just said it, if you look at his inferior leads here, you see ST depression. Okay, concerning. Let's check the rest of the EKG and make sure, oh God, there's ST elevation there. There's ST elevation there. There's a bit of ST elevation there. Not quite so much there, and there it's a little flatter. But this guy's clearly has significant ST elevation, which localizes to his septal leads, and in this case is high lateral leads. When you have ST elevation is essentially a coronary occlusion until you prove that it is not. There's other stuff that can happen. You can get vasospasm, you can get Takotsubo type stuff where, broken heart syndrome, that kind of stuff. But generally speaking, when we see ST elevation, we are going to say this is a heart attack, a coronary occlusion that needs to go get opened up. Now, when you occlude your coronary, it goes through your EKG, doesn't just like all of a sudden, occluded, boom, giant tombstone comes up. It goes through a series of changes. It starts off looking normal. You start to get some ST elevation. Your QRS starts to get smaller. The ST elevation gets bigger. You start to make this Q wave that is not normal in most leads. And it goes through a pattern. And eventually, if you survive your STEMI over the course of several days to several weeks, your EKG goes back to essentially normal, but with the addition of a Q wave. A Q wave is a sign that you had an infarct at some point, generally speaking, if it wasn't there before. A new Q wave is a sign that somebody has infarcted, but it's usually hours to days to weeks rather than in the first couple of minutes or something like that. So ST elevation does go through a different pattern. You can see changes even over the course of minutes to hours. It is worth noting that it is a millimeter. I've got a whole thing on STEMI coming up here, so I'm not going to belabor it too much, but the definition is basically 2 millimeters of ST elevation in V2 and V3, and every place else in the heart, 1 millimeter of ST elevation is significant and enough to call a STEMI, an ST elevation MI. Let's take a break here because I'm tired of hearing my own voice for just a minute. And then we'll get back into how to actually look at this in a more practical way. We've talked about how to do it book-wise, and I've said everything I need to say to, kind of do what the academic side of me says. Let's talk about how I actually interpret stuff and the stuff that I actually look at, and we'll go through this a bit faster here in just a second. So